Starting now, guys.
Okay, so dear colleagues, I think everybody is ready. So we may start our next webinar, which is organized by the two sections, the section of pediatric neurosurgery and the section of vascular neurosurgery. I'd like to say that that all our webinars are
Sergey, can you unmute your microphone?
Oh, yeah. Yes, once more. So I'm sorry. So dear colleagues, let us start. So this is our next webinar, which is devoted to the vascular neurosurgery. And all our webinars organized by the pediatric section, all of these webinars are joined. So they are equally organized by two sections. This time, this webinar is organized by the pediatric section and the vascular section. So, and it's a great honor for me to introduce our outstanding speakers. So I think that we shall do it one by one according to our plan. So, and as I have told you, this webinar is devoted to the peculiarities of the vascular diseases in children. So it is addressed both to the pediatric and adult neurosurgeons. We have chosen several topics which may be interesting for both parts of the neurosurgical world, the adult and pediatric one. And the first topic is devoted to the Moya-Moya disease. So about the peculiarities in children and adults. And the first speaker, Peter Vaikocci. So yes, so this is his presentation. Please, Peter, you are welcome with your presentation.
Sergey, thank you very much. I'm very happy, not only that I'm allowed to speak early with this very niche topic, but that you are also devoting time and interest into the Moya-Moya vasculopathy, or today we would rather say Moya-Moya arteriopathy. That's the more right term. So Moya-Moya vasculopathy or arteriopathy has a typical angiographic experience. Many of you will know it. It's characterized by usually bilateral occlusion of the distal intracranial segment of the internal carotid artery, and then around the bifurcation with M1 and M1 and A1 segments, you will find also hemodynamically relevant stenosis or occlusions. And due to the chronic ischemic state, the very plastic vascular system will then develop these networks, these Moya-Moya typical blood vessels. Moya-Moya is Japanese and means puff of smoke, and certainly because Japanese neurosurgeons were reminded about smoke when they saw these collateral blood vessels. So this is of major interest for the vascular biology field, that these blood vessels are highly plastic. For the neurosurgeons or for the stroke neurologists or for the pediatric people, this is of interest because they can be a source of either ischemic or of hemorrhagic stroke. The patients that we have operated over the past decades are usually 1/3 pediatric population patients and 2/3 adult population. There is one pediatric peak in our series after the age of 11 to 18. We have some patients that were very young and some that were in between. And then there is another age peak in the adult cohort, which is around 30 or 40 years of age. And this talk is now devoted on the peculiarities of the pediatric population versus the adult population. So patients tend to present in different ways. So in our series, we are mainly focusing on Caucasian populations, and there's already a difference between Caucasians and Asians and Hispanic populations. The latter are described in the California series, for example. The Asian series are usually Korean or Japanese, and the Caucasians are a mixture of European patients. And here in the pediatric group and in the adult group, most of the patients will present with ischemic events, either stroke, minor strokes, or repeat TIAs. But then the other presentations are in a way different. Both will present also with hemorrhagic stroke, 12%. It's a little bit more in the pediatric group than in the adult group. 12% of the pediatric population will present with hemorrhage. 4% of the patients, the only thing that is described is headache and neurocognitive decline. Then 8% without headache, only neurocognitive decline, just parents reporting that patients are not doing so well in the school or are developing less well. And then it's an important differential diagnosis in pediatric patients when it comes to seizure. So moya can be one rare differential diagnosis for seizure. If we compare our results or our epidemiology with North America, with the Hispanic series and with the Asian series, it becomes clear that in pediatric patients, especially Caucasians, have a high incidence of hemorrhagic presentation. While in the Asian population, many more would present with hemorrhage among the adult patients. So if you have a patient, a young patient that has either hemorrhagic stroke, seizures, or neurocognitive decline, you should think about moya disease. If it comes to stroke, to rare stroke in the young patient, definitely moya is an important differential diagnosis. Then we also have moya syndrome. Moya syndrome is moya vasculopathy, the typical vascular manifestation, plus other diseases like Down syndrome, like NF2, like craniopharyngioma patients that have been radiated. So these patients, when they present with the typical signs of moya, then they are grouped as a moya syndrome. And again, we find a significant number of patients among the pediatric patients that will present with the same blood vessels. Biologically and clinically, the moya vasculopathy behaves the same, whether it's disease or whether it's syndrome. So we can group them with respect to our recommendations together. And this is very similar to the Asian population, where we also have many pediatric patients in the moya syndrome group. Here, the symptoms are a little bit different. So many, again, will have ischemic events, no hemorrhagic manifestation, at least in our group. And then we have seizures and some kind of blackouts for these kids. And here, 8% were hemorrhagic in our series, and 83% were ischemic. And this is very similar to the other ethnical groups. So regardless whether it's moya disease or whether it's moya syndrome, 10% of the pediatric patients, 8 to 12%, will present with hemorrhage. These are usually deep-seated hemorrhages, and the source of these hemorrhages are these fragile collaterals. Very rarely, these patients have accompanying aneurysms due to the increased stress on the collateral blood vessels. A very important point is the involvement of the posterior circulation. In the European population, pediatric population, 35% of the patients will also have an involvement of the posterior cerebral artery. And the posterior cerebral artery involvement is very important because the posterior cerebral artery and the posterior circulation is an important source for collaterals. Through the callosal artery, they are feeding the ACA and the MCA territory. So if the PCA is also stenotic or even occluded, this carries a higher risk for stroke burden. The stroke will be more significant. The extent of chronic hemodynamic compromise, of chronic ischemia, is more is more profound and will result in neuropsychological deficits, and the stroke risk following successful treatment over some years is higher if we observe that the PCA is involved. So it's important to follow up these patients even after successful bypass operation in order to detect PCA involvement or posterior circulation involvement very early, because if so, this carries a high risk of repeat stroke, of recurrent stroke. And it's also an independent factor for posterior hemorrhage, because an involvement of the PCA will lead to collateralization through the deep posterior collaterals, and they are most prone to rupture. So this is why we have recently written a consensus statement about moya adult and pediatric patients. And here we suggest that the PCA is really something that you should look at because it identifies pediatric patients which are at higher risk of stroke or recurrent stroke. When it comes to revascularization, there are usually two ways to go. The direct techniques, where it's a direct anastomosis, usually between the STA. You can also use the occipital artery to a cortical blood vessel. And then there is a large group of indirect techniques where vascularized grafts are placed onto the brain surface. And due to the plasticity and the angiogenic capacity of the brains, blood vessels will start to revascularize the brain from the graft into the cortical surface. And we call these indirect techniques. There are multiple variations. And if we are discussing which way to go, it's usually direct versus indirect versus combining the two. And especially in the pediatric community, there is the hypothesis that indirect alone will do the job. And I will now discuss with you that this is not true, and this is not what we recommend in our European consensus statements. So the principles of the direct revascularization is that you perform a direct anastomosis. You can either use a small vessel or a bigger vessel. It's minimally invasive, especially in the pediatric population. It's technically challenging, but you should always try to perform a direct bypass, and I will tell you why. Patency rates are high, and the advantage is that you have an immediate flow protection, and you have a large volume of blood flow. It's very difficult to have that volume and normalization of the chronic ischemia with indirect blood vessels. The indirect revascularization is placement of a vascularized graft, either the muscle, the temporalis muscle, or the gallia, or you turn over the dura, and this will result in delayed revascularization. In the adults, it's usually 12 months. In the pediatric population, it's 3 to 6 months, but it takes some time. And during this waiting period, you don't have a protection for the kid for a repeat stroke, that because usually the kids are symptomatic and you would like to protect them immediately. It's usually low flow. On the other hand, it's technically straightforward. You just perform the craniotomy, you throw some muscle onto the brain, and you go home. That's the concept. And this is why it's so appealing to perform an indirect technique over a direct anastomosis, which is usually very tedious. There are different ways for the indirect technique. Either you place the dura, you turn the dura around, you place the temporalis muscle, then it's an encephalomyosynangiosis. You can combine dura, temporalis muscle, and STA layer grafts, then it's an EDAMS, and so on. It's just to give you an impression that there are different variations, but the concept is the same. Lay something on the brain and new blood vessels will grow into the brain. And they are summarized in our book that we have recently published. Then there is the principle of combined. You can also combine the two. You can add the advantage of immediate protection by the direct bypass and combine it with the indirect techniques, which serve as a backup. In case that the direct bypass will not work, the indirect technique will take over. It takes a little bit longer. The risks are not really increased, and it's a little bit more invasive, but it gives you the advantages of both sides. This is from our meta-analysis that we have performed for the recommendations, for the guidelines, and it clearly shows that revascularization of Moya-Moya pediatric populations is beneficial. It prevents further strokes, and this is why in children, all experts suggest to revascularize patients that are symptomatic from Moya-Moya vasculopathy, either by ischemia or by TIAs. If the patients are presenting with fresh TIAs or recurrent strokes, they should be operated immediately. Usually in the adult population, we like to wait 2 to 3 months. In the pediatric population, because the neurocognitive decline is so rapid, you can lose so much brain tissue with chronic ischemia. Here we recommend immediate revascularization. Don't wait unless there has not been a major stroke just a few days ago. And waiting should really be balanced against the risk of the further strokes. And this is, you should be really fast and go for it. And this is really peculiar for the pediatric population compared to the adult population. So now coming back to the techniques, which technique is better? This is an example of a patient where we have performed a combined revascularization, and the result of the revascularization of the indirect technique of the encephalomyosynangiosis is more prominent than the direct anastomosis. On the other hand, this is a patient where the take rate of the muscle was not so impressive, but you can see the large STA, which is almost filling the whole MCA territory. The difference between these two patients is the age. Another peculiarity of pediatric Moya-Moya patients is that the indirect techniques have a higher take rate than in the adult population. In the adult population, it's approximately 50-50. In the pediatric population, the take rate, the appearance of some blood vessels growing in is 90%. But the important question is whether these vessels are enough to normalize the reserve capacity in these patients. And very frequently, the indirect techniques are not enough, which we have shown by post-bypass hemodynamic assessments. Here we are comparing adult in dark versus pediatric in gray, the STA bypasses and the indirect techniques. And it just reflects the advantages of the direct revascularization. Immediately after 7 days, you have a very good protection, and all of the direct bypasses worked. They might not be perfect, it's just a grade 1. A few vessels are filling, but already after 7 days, you have blood vessels that are filling more than 1/3 of the MCA. But these blood vessels mature and they work in the end and give very good angiographic and hemodynamic results. The indirect techniques, obviously, after 7 days, have no contribution to blood flow, and you are relying on the ingrowth of the blood vessels, and many of these patients will end up with insufficient revascularizations. The question is whether indirect or combined whether direct or combined are more risky than indirect alone. And this has been shown by different meta-analysis that this is not the case. Direct or combined are more effective than indirect in terms of stroke rate, and there is no difference in terms of complications. So really, you can always try to perform a direct bypass. You will be, in many cases, you will be successful, but you should not back up because you are fearing the risks. This is why in our series in the young population, we are very rarely performing indirect techniques alone, only if there is no donor or if there is no recipient, but usually we are combining or going for direct anastomosis alone. And this is again back to the recommendations. Here we have compared direct or combined versus indirect, and there's always a trend and a statistically significant benefit of direct anastomosis over indirect anastomosis. And the same is true for disability risks. Although here the difference is not so high, but really if you want to prevent a stroke in the pediatric patient with Moya-Moya, you should go for combined or for direct alone. Do not rely on indirect techniques. And this is what we have recommended in our conclusions. So the conclusion here is that we, in pediatric moya-moya patients, they should be operated early on. They should be revascularized by a direct bypass, either as a standalone or in combination with an indirect technique. We usually revascularize both hemispheres. We start with the symptomatic hemisphere and will continue with the other hemisphere a few weeks later. The hemodynamic results that you can expect are better as soon as you add a direct anastomosis. Now I'm repeating myself, but I think this is a very important point, especially if we are discussing in a interdisciplinary session with pediatric neurosurgeons. Our favorite way to go is to combine the two, because then we have the indirect as a backup. And it might also happen that the direct will become weaker while the indirect are taking over, but the combination of the two is the way to go. And now I thank you for your for attending this session. Thank you very much, and for having me.
Thank you. Thank you so much for this, Peter, for this brilliant lecture. So it was really very interesting and deductive. So, so to organize our work, I propose the following. So we have two moderators, and I will introduce them. Andres Rabe. He's director and chairman professor of neurosurgery from University in Bern in Switzerland, and he's the chair of the vascular section. And Radek Frick, professor, he is a senior consultant neurosurgeon from the Oslo University from Norway. I think that you may introduce the our other lectures, our other speakers, and I will ask you to discuss everything that we hear on this webinar, and in the end of our meeting. So I think that you may summarize those peculiarities which are characteristic to the adult and pediatric populations of this disease. So, okay, please, Andres and Radek, you are welcome. So you may continue this way.
When do you want me to be back for the discussion? I apologize for this question. Discussion will be at
the end.
Yes, I think at the end. So as we decide,
Okay.
Radek, what do you think? So at the end or every?
I think about 6:10 or so, around
6:10.
6:10.
Perfect.
Yeah.
I will be there at 6:10. Wonderful.
Okay. So thank you, Sergey, for the introduction, and thank you, Radek, for having organized and chairing as pediatric colleagues. I think it's a very good idea to put diseases together that are presenting in pediatric and in adult patients. And for me, it's a special pleasure to announce Marco Censato, who's the chair of neurosurgery at the University of Milano di Guardia. He's a very experienced neurosurgeon, very, very experienced neurosurgeon for AVM, and a very, very, very good friend. so Marco.
Thank you. Thank you for the nice
presentation.
introduction. It's a real pleasure to be here, and may share the screen with, let me see if you see it. Do you see it?
Yes, only the black screen. Yes, excellent.
Pediatric AVM, do you see it?
Yeah.
Okay, thank you very much. It's nice to have a talk about this, because often pediatric AVMs are considered something scaring, and there are many doubts about what to do. First of all, we have to consider that stroke is a very high cause of death in children, and most of the AVM, not most, but many of the AVMs are diagnosed during childhood or adolescence. So we have to consider AVM also in children. Notwithstanding the name arteriovenous malformation, now the overall thought is that they are not congenital. This is a paper from Lancino recent that probably they are something like the dural fistula, that you have something happening during the development, and they have to be considered something acquired and not congenital. And probably there is something genetic plus something that happened during the growth of the brain. And this is not anything new, because also Yazogil stated that several years ago. Plus, there are already well confirmed that there are de novo development of cerebral AVMs. So we have several cases, and there are published that there is an MRI without anything, and then you have an MRI with an AVM some years later. And also it's well known that no pial AVM, classical AVM, have been found in newborns or during echography in uterus. So how do they develop is very complex. Probably no one knows it, but there are several factors that interplay together. And plus, there is another thing that can argue for something that is not congenital and stable, is that more than half of the AVM increase in size over time, and some of them also decrease in size or vanish. So they are plastic. They are something that moves in over time. So this is we have a database, a very large database collected between Gamma Knife and surgery and the vascular in the last 12 years. And we have seen more than 100 AVMs, and 800 AVMs, and most of them presented around the 40s, around between 35 and 45 years of age. And most of the ruptured AVM occurs during 30 years of age. But if you do a percentage of the ruptured compared to the numbers, and we can see that most of the AVM ruptured are in pediatric age or in older age. So the pediatric age is something dangerous age, also because many of them presented with rupture. So they do not seem to be congenital lesion, but are they something different than the one of the adults? Probably. They have a more frequency of diffuse nidus. So there are this term that is juvenile AVM, where the nidus is less compact. They are generally smaller. They generally are deeper, and most frequently they have a deep venous drainage. They have less artery aneurysma rather than compared to the classical adult AVM. So diffuseness is a very important element of the pediatric AVM, because they are, from a surgical point of view, diffuseness is a big problem because there are two complications. One, you can have a dissection too close to the nidus, so it's very it's difficult to maybe you can risk to leave something behind the abnormal portion of the nidus. And otherwise, on the other hand, you can have a dissection too far from the nidus. So maybe you can take out a brain that does not need to be taken out. This is an example. This is a diffuse AVM of a child that had bled, and this is the AVM, but you see that the margins, the contour of the AVM is not very neat. There is some, the AVM is somehow foggy on there in peripheral side. And so this makes difficult to understand where the nidus is finished. And this is the AVM before, and this is after surgery. But if you see here, there was a remnant below the AVM. So we had to go back and take it out also. But the problem is that in the beginning, in surgery, here you have white matter between the two parts of the AVM. So it was very difficult to understand where to stop. Sometimes it's difficult to discriminate between diffuseness and recurrement. Also, this seems to be foggy. This is another AVM that seems to have a very wide and not very clear margins. But at the end, this is not a diffused AVM like this one here, where you have deep white matter vessels, but all these impressions are at the end pile vessels that were recruited and go down in the sulcus and then come up. So they were very easy to take out. So the differentiation between diffuse and compact sometimes can be hard. Also, you can have something like this, which is also a very wide AVM with a very foggy margins, but this was at the end a proliferative angiopathy and not a real AVM, and it was in a child. So it seems to be they are two different. They have some different characteristic of when they are pediatric and rather than the adult. And so the question is what to do. Do they evolve over time? So it's better to wait, or it's something that they are two different conditions and they do not have any evolution. In other words, when you have a diffuse AVM, are they immature? And so it's better to wait if they mature in something more easy to treat. We did a study, and we are ready to publish it. We evaluated the diffuseness with this very easy scale that has been already confirmed with a reliability. And you see, this is a diffuse AVM, this is an intermediate one, and this is a compact. And we took all the AVM we treated, and then we concentrate on the first 40 years of age, and you see that these are the red ones are those considered diffuse or intermediate, and you see this here is the age, and these are the compact ones. But if you normalize it, you see that there is something that changed. But you see that how in before the age of 30, you have a much higher concentration of diffuse and intermediate AVM rather than compact. And idea is something here is different. And we did the study, we put them together, and at the end there was a real p inferior than 0.0005, and the best cutoff age was 28.5 years. So this is the curve that something seems to be different between and after, before and after that age. Why? We don't know. Probably there are some literature which is, I don't know how reliable and what's the relation with that, but the maturation of the brain seems to end much higher at an age much higher than 18, the classical 18 years old. So probably there is an evolution of the brain until the age of 25. And so also this paper from Lawton and Kim and Lawton and the others, that they find that there is not a significant statistical difference between sharp and diffuse AVM. Probably if you consider only the age of 18, probably that's true, because if you see here between the age 18 and after, it doesn't change anything, but probably something could be considered in an older patient. So having said that, what to do with the kid? Of course, no doubt is no one has doubt concerning the ruptured AVM, but the main problem is what to do in an unruptured AVM in a child, and so you have two choices: let them live without harming them, do not touch them, wait for something happening, and probably maybe guessing and hoping that nothing will happen, or the other possibility is to do something to prevent a future damage. And so we had with Andreas, with Peter, and with many other neurosurgeon and neuroradiologist and neuroradiosurgeon several years ago, after the Aruba trial, a consensus conference that concerning the young patient, there is at the end the consensus of most of the neurosurgeon, interventional, and neuroradiology that it's better to do something in the child, and so prevent a future damage rather than waiting for something happening. Also because although in a child maybe there is the fear that something can be damaged in a child, there are the capability of a child to compensate and to reorganize the function in the brain are much higher than in adult ones. Plus, epilepsy can be also a problem for AVM. So many of the AVM beside to the bleeding, there many of the AVM can present also with epilepsy, and leaving a patient, a child with epilepsy can be also something that can be very invasive rather than considering surgery that probably can treat it. Then this is another paper that says that neuropsychological performance after brain arteriovenous malformation treatment in child at the end does not cause deterioration in neuropsychological performance. So there is no high fear to treat a child, and we consider that it's better to treat. This is another paper that we published that is At the end, the number of complications we assisted the patient that had some neurological problem after treatment of unruptured AVM compared to the one that has been treated after rupture is much different. 1/3 of the patients that came after rupture remain with a severe, with a moderate to severe disease deficit, while after treatment, when the AVM is still not ruptured, the numbers are much lower. And so we think that if you consider the probability that an AVM will rupture over time, and if you consider the probability of having a damage after surgery, the two curve can be will overlap in 6 years. So in a child, of course, this is, in our opinion, is worthwhile. If you consider the most of the AVM ruptured around the age of 30. So if you can prevent this, is, in our opinion, much better. You see, these are the treatment we had. We have a lot of gamma knife when there is unruptured deep eloquent AVM, and embolization is not something that we consider as a treatment, a reliable treatment. You see, is very low, the number of embolization, and we use embolization only to treat ruptured AVM, where often you have an ruptured aneurysm, a pseudoaneurysm, or to use a treatment, endovascular treatment in preparation to surgery. And this is an example of how they treat. And then in many cases, when you are in an eloquent area, we can embolize and then go for gamma knife. Although there is a question about the long-term risk for gamma knife in childhood, but at the present data, or gamma knife is already around for 30 years, so probably there is no evidence that can create a problem after a long time. The last consideration is that, of course, you have to consider the eloquence. You have to consider the possibility to have a deficit, and in our experience, almost half of the AVMs are in the parietal occipital area, probably because this is the territory where the three circulation connect, and probably something happened there during development. But the problem is, you have to consider that if you cause a hemianopia, is really a big problem for a complete hemianopia has to be considered a serious disability. While in our experience, in the patient we have done, a quadrantanopia is not such a big deal in a child. And considering a child also, you have to understand that after surgery, many of the parents are very happy when their child goes home without any big problem, and they talk and they move and they are happy for that. But if you consider the patient when there is a high expectation after surgery, and immediately after this is enough, but then waiting for 5-6 years, when they see that something do not improve, their opinion is more negative. So it's something that you have to consider, that we as a surgeon, probably we consider it talks, it walks, and everything is fine. But over time, a deficit can be a big problem also in the child. And it's interesting that to see that interview with the mother are more concerned about the outcome rather than father, that are much more easy about that. So last topic, and then I will finish. In pediatric AVM, you have to consider also a follow-up. It has been known that well known that the AVM can recur, and I will show you a case. This was a 9-year-old child that has been operated elsewhere in 2000, and this was an hematoma. This is the MRI after treatment. 1 year after, and you see here we don't have the angiography because the patient comes to us without the angiography, but you see this is the MRI and you don't see any residual. Seems to be very clean and outcome, and the patient was fine. But then 19 years after, when the patient was 28, she came with this AVM. So it was a recurrence. You see here how big was it, and this was an AVM that apparently was completely removed by surgery, but at the end she came with this AVM that has to be operated again, and this is the final outcome. This is not such a big deal. So concluding, they are different. Probably they are more diffuse. Probably they evolve until the age of 25, 30. And so when you have an unwrapped, very complex diffuse AVM, it's interesting to follow it over time. There is no confirmation that this is something that can be that can evolve, but there is a suspicion that this can be useful. There is an indication to treat also in child, in our opinion, and there is an indication for a strict follow-up until the age of 25, 30. Thank you very much. I hope it's okay.
Thank you, Marco. Great presentation, and I think you really nicely showed the peculiarities of the pediatric population with all the difficulties that arise. I think we spared the discussion for the end of this section. It would be interesting to know your approach about follow-up and how often we see a relapse and so on, so we can discuss this later on. I'd like to hand over to Radek for announcing the next speaker, and then we move into the true pediatric territory.
Okay. Thank you, Andreas. I hope you all can hear me, and I'm very glad to see that the seminar has attracted some attention. Now we will be talking about a very rare pathology that is almost exclusively linked to pediatric patients, the vein of Galen malformation, which is a very peculiar disease. And I'm glad to see Professor Sergei Yakovlev, who has a vast experience with this pathology. He's the chief of neurovascular department at Budenko. So please, Professor Yakovlev, share with us your experience.
Good afternoon, dear colleague. I want to present our experience in treatment of vein Galen arteriovenous malformation in our center. In different researches used various terms for the description of this pathology. Now the terms offered by Lazunius, Pierre Lazunius, accepted as vein of Galen aneurysmal malformations. Vein of Galen aneurysmal malformations are rare congenital abnormalities, are characterized by the presence of an aneurysmally dilated midline deep venous structure feed by abnormal arteriovenous communication. The statistics reveal a frequency less than 1 to 25,000 deliveries, and 1 person of all intracranial vascular malformations. And not treated malformation is followed by the high level of mortality, and such as 30% mortality of vascular malformations in pediatric group, and 90% mortality of newborns, and 35% in children aged before the 7 years old. Abnormal development of arteriovenous shunt occurs between the 6th and 11th weeks of intrauterine life, described variable. There are associated congenital abnormalities such as Turner syndrome, Ravel-Black syndrome, supplementary digits, hypospadias, transposition of red vessels, aortic stenosis, and right-sided tachycardia. The anatomy of this AVM is very complex. You can see the anatomical preparation filled by latex, the performing in our center in 1990. The clinical symptoms reveal the macrocrania, hydrocephalus, cardiopulmonary congestion, epileptic seizures, focal neurological deficit, and psychomotor retardation. And rare symptoms is intracranial hemorrhages. The clinical presentation is different in such age groups. In neonates, with newborns, it is characteristic with a high flow multiple shunt, with a congestive cardiac failure more than 25%, from asymptomatic cardiomegaly to severe cardiac failure that is refractory to medical management, cyanosis, and myocardial ischemia. The next group is infants and children have a low, mild, and low flow fistulas, and presented as cardiac manifestations are absent or very mild, and macrocephaly and hydrocephalus, psychomotor retardation, epilepsy, and focal neurologic deficit. And last group is older children and adults, presented low flow fistula with developmental delay, focal neurological deficit, proptosis and epistaxis, subarachnoidal and intracerebral hemorrhages. The classification there are 2 types of AVM. The mural type with a high flow, usually single fistula, is formed by branches of lateral, posterior choroidal artery, and follicular arteries. You can see on this schema. Choroidal type is usually develop with branches of AC, anterior choroidal artery, MC, and medial posterior choroidal arteries, presented as fetal limbic cycle. Pathogenesis of cerebral clinical presentation, it is caused by 2 factors: intracranial venous hypertension due to decreasing of arteriovenous difference and decreasing liquor absorption and hydrocephalus, and local compression compression symptoms in case with high level dilated of venous pouch and presented as hydrocephaly and focal neurological deficit. A natural course of studied by Laginius and other, and summarized in this schema. Optimally therapeutic window was determined as the age from the birth to 5 years. Due to 30 years, we are carried out 225 patients with prevalent male patient and aged from 3 weeks to 18 years old. The diagnostic option was antenatal ultrasonographic examination, neonatal ultrasonographic examination, MRI, CT, and BCA. BCA used only in as a first stage of treatment of endovascular treatment of AVM. You can see in antenatal MRI, you can see dilated vein ganglion in different projection, and you can see pathological blood flow in this pathology. The clinical symptoms you can see here, and most of patients have subcutaneous vein dilatation of scalp and face, and increase in cranial circumference and hydrocephaly. Treatment was the first line is endovascular treatment, endovascular embolization. Direct surgery performed on the 4% in the early period of our experience. And radiosurgery underwent the patient with age more than 4 years old, and combined therapy. The shunting operation usually performed after endovascular embolization. Most of patients underwent endovascular treatment, you can see here. And angioarchitecture present as moral type, and most of patients have a horizontal type. The choice of endovascular treatment was the moral type. We use transarterial occlusion by feeders, using by Colts and balloons, and in horizontal type, we perform a transarterial or transvenous embolization and using combining approach. The most of patients have a good clinical results, stable and improving and clinical symptoms, and mortality was in 1. Mortality and morbidity have 1% equivalent. The cause of mortality was massive intracranial hemorrhage. In one case, acute occlusion of ciliary aqueduct and dislocation of brain, one patient, and multi-organ failure, only one patient. I can see some clinical cases. This is a male child, the age of 9 months. The vein ganglion malformation of moral type. We are performing a coiling of apparent vessels with totally exclusive from blood flow IVM. Next case, the moral type of vein ganglion IVM with giant dilatation of the vein and ventricular megaly. We have performed 3 stages of endovascular embolization and achieve a total occlusion of AVM, but we need to perform the ventricular abdominal shunt. You can see on this picture that vein is decrease in size, and pathological blood flow was excluded. The horizontal type of arteriovenous malformation is very difficult for treatment. So in this case, we use adhesive glue, NBC, embolization, and resulting as a subnatally occluded malformation. Next, horizontal type AVM with Moya disease. We use a partial embolization and clinical symptoms of stabilization. A very good perspective have a non-adhesive agent such as onyx or squid, and use you can see super selective cauterization of afferent vessels, and result is totally occluded IVM. But using this agent is limited because DMCO, the solvent, organic solvent, is very toxic, have a toxicity. And one of case I've described in 22, yes, by our director Konovalov, Alexander Konovalov, who performed the surgical removal of the thrombosid venous vein with good clinical result. Long-term outcomes from 1 to 10 years revealed very good clinical symptoms and a low level of morbidity and mortality. This is patient underwent endovascular embolization of moral type of IVM. And this is post-operational result, total disconnection of arterial shunt. This is MRI before operation, and 1 year later. You can see that venous vein is disappear. And clinical is very good result. So the clinical outcome that is very good. Now we need motor, another symptoms good develop. In conclusion, our recommendation: do not use direct surgery because endovascular method is highly effective and non-traumatic method in treatment of vein-Galian malformation with low level of morbidity and mortality. Endovascular treatment should proceed a shunting operation if it is possible. Severe neonatal cardiac failure secondary to vein-Galian malformation is not an absolute contraindication to interventional treatment. And application of new technologies allows the increasing quality of endovascular interventions and improving results of treatment in early period of life patient with vein-Galian malformation, especially before great cerebral damages. This is our patient who underwent endovascular treatment. We're glad to see the clinical result. It is our staff. Thank you very much.
Okay. Thank you very much for your nice presentation showing the vast experience that you have gathered at your institution. I may imagine that there will be a lot of questions at the end of the session. But for now, I would invite our last speaker, who is Yuri Filipenko, who is also working at Budenko. He's another vascular neurosurgeon, and he will take up the topic of intracranial aneurysms in children, which is also a very specific issue, and in many senses very different from adult ones. So please, Professor Filipenko.
Thank you, Radek, for introduction. And thank you, organizing committee, for invitation. It's a big pleasure for me. And my topic, do you see my presentation? And my topic,
Yes.
Thank you. And my topic about cerebral intracranial aneurysm in children and features that distinguish this pathology from adults. General information, among all cerebral aneurysm in children, find only 2 to 3%, and this rare pathology, but very dangerous because complication of natural cause has poor prognosis. And of course, this is non-congenital pathology. I think is known information, and in 1/3 of cases, we can establish factors predisposing to aneurysm formation. This is according to our data. And we had investigation where we compare two group of patients, children and adults, and different periods and age groups. Of course, the majority of patients were adolescents, but sometimes we found this in newborns and children first year. Clinical manifestation more often in this was hemorrhage, and the complications associated with hemorrhage, rebleeding in children twice, two time more in children than adults. Also chronic hydrocephalus, seizures, more typically for children. Location, most typical location was internal carotid artery for children, and also there are a lot of posterior circulation aneurysm in pediatric group. Another complex features were giant size, partial thrombosis, and fusiform anatomy. This is more frequently in children. About treatment, of course, there is no conservative treatment, but sometimes we leave such cases for observation, especially in patients without symptoms. And another situation when we diagnosed complete spontaneous thrombosis of aneurysm. This event are typical for children, more typical for children than adults, 7% in children. And also very important information, 70 patients had thrombosis with occlusion of parent artery that in 1/3 of cases led to progression of neurological symptoms. Several examples, patient, male, 13 years old, hemorrhage from micro aneurysm of posterior choroidal artery. And when we repeated angiography in 3 months, we revealed total thrombosis. Another case, 2 months girl with hemorrhage from ACOM aneurysm. Aneurysm was thrombosed with one of A2 segment artery. Another case, large aneurysm, internal carotid artery, aneurysm thrombosed with ICA, and it followed by ischemia in left hemisphere. And summary about thrombosis: the most probable nature are idiopathic or traumatic dissection or infection. And since the mechanism thrombosis are not fully understood, we recommended surgery in majority of these cases, like a first option of treatment. And surgical treatment, this is our data. We more often prefer microsurgical treatment in children and reconstructive operation in majority of cases, 67%, which include clipping, coiling, implantation of fluid diverters and setters. Examples, typical cases was easily treated, coiling, in this case also coiling. And here you can see implantation, flow diverters. And this slide, you can see aneurysms in children of first year of life. I think you agree with me, it is very difficult to perform reconstructive operation, in this case, especially by endovascular route. And that's why we performed microsurgical intervention, different types of complex surgical clipping with good results in all cases. So we collected our material for a long period, and about 31% of patients had reconstructive operations. And one of our conclusion was that the reconstructive operation may be treatment of choice in this group, because children tolerate this surgery very good. Examples in this patient with basilar artery aneurysm, both vertebral artery were occluded and by endovascular route, and this is the follow-up in 6 months, almost total disappearance of aneurysm. Another case, giant partially thrombosed fusiform MCA aneurysm also was occluded by endovascular proximal coiling, and in 6 months significant decreasing of aneurysm with good clinical results. Bypass surgery, this is trends of last decade. Among all of children with aneurysm, 11% bypasses were performed. And other side, among all bypasses in our center, 18.5% were performed in children. Examples, this case, a patient with significant visual impairment, and this is operation. Aneurysm was trapped and double barrel bypass MCA-STA was performed. And early recovery, 8 days post-op, you can see significant improvement of visual disorders. Another case, male, 12 years, with giant partial thrombosed vertebral artery aneurysm and the pica origin from a lower chamber from aneurysm, and right picture occipital artery. We take it and perform bypass between it and pica, and this is a video of surgery. Unfortunately, I have enough time to demonstrate all of, but very briefly, this is pica origin from aneurysm. This is proximal part of lower chamber aneurysm. Aneurysm was partially thrombosed, and this is bypass between occipital artery and pica. After it, we perform trapping, lower chamber by 2 clips. Aneurysm was open and thrombus was removed from aneurysm. And after this, this is result. first day after surgery, patient 7 days post-operative, and control angio. We reveal good feeling bypass, and also we reveal upper chamber. It was planned, and in 2 months we performed the second endovascular operation, pipeline implantation, like this, and this is the result in 3 months total recovery with good clinical outcome. This our general results: Glasgow outcome scale, low mortality through the children, and good clinical results. And of course, we don't forgot about follow-up angiography. In this case, sometimes it is necessary to perform a repeat surgery. For example, in this case, aneurysm was coiled, 2-stage coiled, and after follow-up angiography, we decided to perform clipping in this case. Another case, unsuccessful clipping of aneurysm. In 1 year, we reveal remnant, significant remnant, and after that we performed by high-flow bypass with radial artery, good clinical result. Another interesting case, patient female had giant aneurysm of anterior cerebral artery, and also she had large fusiform dilation of the left middle cerebral artery. First stage was proximal clipping of giant anterior cerebral artery aneurysm. This is a control angio. As in 3 months, we reveal significant increasing of middle cerebral artery, fusiform middle cerebral artery aneurysm. And it was a big challenge what to treat it, because there are a lot of lenticular straight artery performance origin from aneurysm, and we decided to perform proximal occlusion, a double barrel MCA STA bypass. This is results after surgery, and in 6 months we revealed partially thrombosis of aneurysm, but total thrombosis we diagnosed only in 2 years after operation, fortunately for patient without any neurological deterioration. And also, but de novo aneurysm is a big challenge for children. We revealed 8.5% de novo aneurysm in children in follow-up. And of course, the majority of these patients have to be recommended follow-up angiography. Conclusion: due to good reparative capacity in children, the contraindications for surgery in this group of patients, of course, should be minimized, and the main purpose of treatment in this group have to be maximum completeness of aneurysm exclusion. Thank you for your attention.
Well, thank you very much. It was a very nice overview and impressive results from your treatment. Now I will ask Andreas to start the discussion. The first topic, the Moya Moya. There is only one question in the box.
Yes. We would like to take the occasion also to ask you to put your question into the QA box so that we can send them to the speaker. There's one question regarding the Moya Moya treatment. Peter?
Yep.
You can read them. I just read them.
I cannot see them. Where is it? Can you read it?
Peter, you mentioned early bypass in pediatric patients, and the question is if there's any limitation for a minimal age. So what is, or when is it technically not feasible? Is there an age limitation down?
As shown in my in my slides, we also operated on patients that are at the age of 1 year. So going by age, there's not really a limitation. The problem with the very young kids is that they often have very severe disease courses with a atrophy of the brain. So sometimes the cortical surface is a few centimeters below the bony surface, which makes it difficult to revascularize, or there's no recipient vessel because this vessel is small or there has been surgery before. So there are limitations rather on the technical side than on the age side.
Okay, so what is the youngest kid that you saw with Moya Moya?
The youngest kid is less than 1 year.
Okay.
6 months.
6 months. Second question regarding Moya Moya. Can the bypass be affected by Moya Moya? Can there be somehow an involvement of the bypass graft?
No, so interestingly, from what we know is that the vascular changes are brain or CNS specific. The extracranial vessels are not affected. However, the anatomy of the STA is also a little bit different, more elastic fibers. And this is why when you do the follow-ups after 1 year, 3 years, 5 years, you see that these bypass grafts, they do not occlude or become stenotic, they rather mature. They have an increased tortuosity and the diameter is increasing. And this is why some of the STA grafts have better filling after some time than initially.
Okay. Thank you. And a third question regarding Moya Moya. The question is this a genetic disease?
It is a partial genetic disease. There are familiar cases with increased manifestations of Moya Moya. They obviously have a genetic background. The genomic analysis and mutational analysis have shown that there is a gene called RNF213, which is a zinc finger protein. The role of this protein is not very well known in vascular biology. Usually something with signaling and proliferation in endothelial cells. However, this mutation is more frequently found in the Asian population. There you will find it in 80 to 90% of Moya Moya patients. However, in the Caucasians, very rare cases have this mutation, which suggests that this is a susceptibility gene. If it's mutated, you need a second hit in order to acquire the Moya Moya phenotype. If you don't have this mutation, then there are other ways how you can acquire which are unknown.
Okay, so that's from this side. So maybe Radek, you can continue with that.
I can see a question on the follow-up, which was also my question. First, regarding the AVMs and also aneurysms. So it's maybe a question to Marco and Yuri. We all agree that it's very worthwhile to follow up closely kids with vascular malformations, specifically after treatment. But when they become older and adults, what are your ideas about the further follow-up of your patients with AVMs and aneurysms? Please, Marco first.
Well, there is no definite answer. We think that could be the question is at least at the age of 25 and 30, probably, because something could be changed there. We have no definite answer. For sure, if there is a kid below 10 years of age, at least for other 10, 15 years, it has to be controlled over time.
And in terms of AVMs, I mean, after completed treatment, where you have a negative angiography and you're happy about the result, what would be your follow-up and how, MRI, angiography, or
MRI. Generally, we use MRI, and then if there is some suspicion, of course, we ask something more deep. but the MRI can be enough to see if there is something wrong.
Yeah. And what about the aneurysms, Yuri? How do you follow your patients after completed treatment?
For your question about aneurysm, because comorbidities in this group of patients exist, and I think my opinion that follow-up are necessary for all of life in times in 3-5 years periods. That's my opinions, and best investigation is CT angio for this group of patients. And if you look, I answer about AVM. My opinion about AVM. If we have total removal of AVM by microsurgical, it is very rare we see de novo or residual malformation, but in adults. But in children, I saw several cases when we total removed malformation, and due to neogenesis in couple years, we can see residual parts. Only in children this phenomenon was possible, but in adults I didn't see de novo malformation yet. This is
Yeah, well, in children it has been described that 14% of the cases can have a regrowth. It's very, of course, you have to monitor and you have to check for a little vein in the post-op angio. If there is any little vein, there is something suspicious, and you have to check it. But I agree with you. There is. In adults, it's very rare. In child, is frequent.
Yes, it's possible.
That's very good, because now you answered another question from the box about the recurrence rate. And we have also one question regarding the vein of Galen malformations. There is a question regarding possibilities to treat these before birth. What is that, Sergey?
It is very difficult. I read one publication in 1999. Maybe it's Japan. They have theoretical description what to do when we have treat in uterus. But now we are don't ready to treat this option.
Okay. It's only
maybe it's maybe in future the possible.
Okay, thank you. Maybe there's a last question, which really is an intellectual challenge to us all. There's a colleague asking about the possible role of artificial intelligence in general, and like machine learning in particular. How can it be adopted to improve the outcomes after treatment of vascular diseases, cerebrovascular diseases in children? So I don't really know what the answer could be, but maybe some of you can do some philosophy about it. Because we really need to care about the future. So in future, the artificial intelligence will improve a lot of our work, but what role can it play in cerebrovascular diseases?
Once I read a book that said that one of the more at-risk profession for artificial intelligence are doctors, because we are a database. We have all we know is experience, so something you have already seen or something that you have studied. So artificial intelligence with a large database can be interesting for us. But at least as a surgeon for the moment, we still have a role. So I think that it's something that can be interesting in large databases, and so to handle and to try to find something that we don't understand now from huge and large database. Probably this can be interesting, but for the moment I don't see a significant role. I don't know if you have played with ChatGPT. It's nice, it's interesting, but it says a lot of bullshit.
Okay, I can see two other questions showing up now. The first is regarding the use of intraoperative neuromonitoring in AVM and aneurysm surgery, specifically to Marco and Yuri. Do you have any ideas, any practical points? Do you use it in this kind of surgery?
Do you want answer, Tenko?
Thank you. My answer is thank you for your question. The answer is that neuromonitoring is very, my opinion, not very useful in this pathology because AVM, for example, my opinion about AVM, it is not a tumor. It is impossible to remove it partially. It is necessary total removal, and due to, of course, we know we have to know where is movement areas, but it is not too useful for by neuromonitoring. And about aneurysm surgery, my opinion, sometimes it helps us, especially in cases where we are going to trap segment, arterial segment, and sometimes it's necessary to understand what perforance origin from arterial segment, and we perform temporal clipping, and after this we check neuromonitoring if movements and sensitive answers find. We perform, for example, pre-trapping. I mean, in cases of bypass surgery. For aneurysm, it's more useful, my opinion, that for AVMs.
May I say something? I agree. I totally agree, because I think that you have to think in advance if an AVM can be removable or not. And so you have to study the function and probably topography and something before, and then once you start, you cannot stop. So I think the advantage of neurophysiology in AVM is not such a big deal, while it's fundamental for me in aneurysm surgery. Even the simplest, I think that neurophysiology is something that is very useful. And what I would like to point out that the main goal of monitoring is to assure you rather than worry you. So in many cases you can put a temporary clip and nothing happens. So you have time. You don't have to be in a hurry. You can work better in many cases. Most of the cases, I would say. Then in some few cases, when you put a temporary clip on an M1 or something like that, then you have something, and so you have to. But in most of the cases, endovascular neuromonitoring is something that keeps you calm. Don't worry, you can go on and do your work at the best.
Yes. Please, Andreas.
Yeah, I think we are running out of time, and I would like to make a little wrap up for the vascular section. So basically, Peter Wajkowski, he nicely showed about the difference in pediatric and adult moya-moya disease and moya-moya. We learned a little bit more than usual about the indirect and direct revascularization, that we still should go for the direct ones. For Marco, we saw a very nice presentation about the pediatric AVMs and the difference to the adult ones. I mean, one of the remaining questions will always be, when is somebody grown up? When is the brain mature? We see this in our kids. That takes a long time, longer than 18 years. And the question is also how dynamic behave AVMs in this phase and maybe later on in life. So thank you, Marco. And I would like to hand over to Radek for the next two speakers to make a little wrap up, and then to Sergey for the final comments. Thank you.
I would also like to thank you, our speakers from Budenko, who could provide us with their vast experience with quite rare diseases. Also, Galen malformation is a very peculiar disease that most of us encounter quite rarely. It was very nice to see your experience from such a huge amount of patients. And other peculiar diseases, of course, intracranial aneurysm in children. So it was very interesting to hear your thoughts about this. So please, Sergey, if you can conclude our webinar. I think it's been very successful. We had many attendees. Please.
Okay, dear colleagues, honestly to say, when we planned this webinar, I was afraid that it will not attract much interest, especially from the part of the pediatric neurosurgeons. But nevertheless, you have seen that we had a great amount of participants, about 180 participants. And this topic really is very interesting, not only for the adult neurosurgeons who treat the majority of the patients with the vascular pathology, but for the pediatric neurosurgeons as well. So, and it is very exciting. So I want to thank our brilliant speakers and panelists who represented the leading centers in Europe, from the Charité Clinic in Berlin, from Burdenko in Moscow, from the universities in Oslo, Bern, and Milano. So this was the real board of experts in this field. And as well, I want to thank our very attentive and active participants who asked a lot of questions. So thank you to all of my colleagues and friends. And I'd like to announce that our next webinar, organized by the pediatric section, will be devoted to the tumor. So I hope that it will be shared with our oncological section in ENS. And I think that it will be devoted to the treatment of the low-grade gliomas. So is it the same disease in adults and children? So it is planned for the 11th of October, so after the vacancy period. And so I invite everybody to join our next webinar. So once more, thank you, and looking forward to meet you in Barcelona. Thank you.
Thank you all. Bye-bye.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Thank you very much. Bye-bye.